Welcome. I'm Mireille Jacobson, and I'm moderating today's Schaeffer Center for Health Policy and Economics webinar on palliative care. At the Schaeffer Center, I'm a co-director of the Aging and Cognition program, and I'm also an associate professor in the Davis School of Gerontology at USC. Our goal today is to discuss palliative care, its value, the barriers to its widespread adoption, particularly amongst diverse and underserved populations, and the outlook for palliative care access in the current policy environment. I'm very pleased to have leading national experts in the field for today's discussion. So I'm going to start with an introduction in alphabetical order of our three guests. So first we have Dr. Sherry Ling, who is the Deputy Chief Medical Officer for the Centers for Medicare and Medicaid Services, CMS. She's a gerontologist and board certified geriatrician, rheumatologist and internist. Dr. Ling supports CMS actions to improve health outcomes for beneficiaries, families, and caregivers through the delivery of high-quality, person-centered care across settings. We also have with us Dr. Sean Morrison, who is the Ellen and Howard Katz Professor and Chair of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai, and the Director of the National Palliative Care Research Center. He is a health services and clinical investigator focused on developing and evaluating models of palliative care delivery. And he also co-chairs the National Quality Forum's Geriatrics and Palliative Standing Committee and its members' Application Partnership Hospital Committee, which is a public-private partnership convened by the National Quality Forum in partnership with CMS to provide input to the Department of Health and Human Services on the selection of performance measures for public reporting and value-based care. And last but not least, we have Dr. Tom Smith, a medical oncologist and palliative care specialist who is the director of palliative medicine for Johns Hopkins University School of Medicine and the Harry J. Duffy Family Professor of Palliative Care. He's also a professor of oncology at Hopkins. Dr. Smith began Johns Hopkins hospital-wide palliative care consult service, as well as an inpatient unit, and he is dedicated to accelerating palliative care research and education. So thank you all for joining us today. For today's program, we're going to start with a discussion with our three guests, followed by audience questions. But audience members, you can submit your questions at any time using the Q&A feature at the bottom of the screen. We will try our best to accommodate as many questions as possible. So to get the discussion going, I want to just first make a few comments about the value of palliative care. So palliative care experts usually point to the many studies, including randomized controlled trials, which are really the gold standard for evidence, showing that palliative care programs improve patient and caregiver quality of life and reduce patient symptom burden. And of course, there's the now famous study by Dr. Jennifer Temmel and colleagues showing that early palliative care not only improved quality of life and reduced depression, but also increased survival by nearly 3 months for patients with metastatic non-small cell lung cancer. At the same time, there's more suggestive evidence that palliative care may even reduce healthcare spending, which is kind of a rare case where an intervention may both improve quality and lower costs. So I want to kind of turn it over to the panel to make some opening remarks centered around why, given the existing evidence, they think palliative care is still not widespread. So Dr. Ling, I'll ask you to start going again in alphabetical order, followed by Dr. Morrison and then Dr. Smith.
Terrific. And first, let me begin by saying thank you. And I'm just so delighted to be with you today as a alum of the Leonard Davis School. And for those of you who may be wondering, I think certainly my training in geriatrics has been really critical in the work that I do and the support I lend to the agency, but how the system works and how to think about the systemic opportunities to improve and how to communicate that, I actually learned prior to medical school. So many thanks to the Leonard Davis School. So just by way of context, so CMS is really charged with the mission of providing care and services to meet the healthcare needs of the beneficiary, the people who are covered by Medicare, by Medicaid, and also by the marketplace. And this number is about 170 million right now. So in doing so, CMS is a very operational agency and takes actions and puts in place policies that authorizes the agency to do so. Now, as part of the Department of Health and Human Services, CMS is now following what the requirements of the Evidence Act, which really requires for policies to be more evidence-based. And I think that is a huge recognition of the importance of evidence, not only for research purposes and for the generation of knowledge, but to be able to translate that into improving outcomes as applied, including people with serious illness and chronic conditions. And why and what are the causes of the degradation of that signal from evidence into practice? It really is multifaceted. From the programmatic standpoint and the policy standpoint, I think we still suffer from definitional confusion, whether it's real or perceived. And this is on many, many levels, right? It is the people who are served and receive care and services. There are the practitioners and healthcare providers who also, there are many, many activities and challenges that they face day to day. And in order to get to the right care plan, develop the care plan that then is implemented and followed over time, I think is another challenge. This is an area that we've been really, really interested in, and it started under the last administration through the Patients Over Paperwork initiative, understanding what the impediments are to the care and services that are evidence-based and that we believe would make a meaningful difference in achieving health outcomes for the people who we serve. And the opportunities that we take to implement the evidence really are by way of, Sean is leading some of the National Quality Forum efforts, and it comes into the policy actions, including quality measurement, which is about the measures, but how they're used, quality improvement, coverage, payment, all of the above. I think the mistake that we make is that, and perhaps it's the questions and asks that come to CMS, but it always starts with payment. And I think payment is necessary, but certainly not sufficient. As we have really witnessed over the past years, making available care and services, that means there are billing codes to really enable and support the care delivery, and yet those codes are not utilized even when they're available. So let's not stop with payment. So with that, I will turn it either back to you, Mirelle, or to Sean. Over.
Yeah, Sean, Dr. Morrison, please.
Thanks, Murray. And I'm going to highlight a couple of things that Sherry said, but also come back to your question, which is, could we imagine if we had a new drug for cancer that we could demonstrate improved quality of life, reduced symptoms, made you feel better, and indeed gave you about another 2 months to live? We certainly, everybody who is eligible for it, would want that drug. And if we think back and make the analogy to palliative care, why hasn't there been that same uptake that there could have been for a pharmaceutical agent? And I think there are really 3 reasons for that. And first and foremost is the misalignment of incentives. Where we've seen the large-scale growth of palliative care is in sectors, i.e. hospitals, where the cost avoidance from palliative care is married to the quality outcomes that it achieves. And there's a reason that we've seen hospital palliative care grow from 5% of hospitals to over 3/4 of hospitals in a little less than a decade. And that's because the financial incentives align. When we look to where else palliative care is growing, it's growing in Medicare Advantage plans, and particularly areas where there's becoming a merger of providers and payers, where payers are becoming providers and providing health services. Optum is a terrific example of a private sector organization that is ramping up its palliative care programs, again, because in that area, the incentives align. In the rest of healthcare, for the moment, the fee-based or fee-for-service system that we have doesn't really align with the value that palliative care provides. And I think for many of us still with our back foot in fee-for-service medicine and our toe into value-based care, until we step forward, we're probably not going to see the growth that we really need. The second reason, I think, is, as Sherry put it, it's definitional confusion. One of the things that we have not done well as a field is truly define for our patients, for our families, for our payers and our providers, what is it exactly that palliative care is, and what does it do? And there is still confusion around palliative care, hospice, end-of-life care, supportive care. And until we clearly define what it is we are providing to our patients and families, it's going to be hard to get uptake. And then I think the third issue, and this is the one that really keeps me up at night, is the fact that we really don't have good quality outcome measures that are both tracking and evaluating the care we're providing. And that keeps me up at night because this is the most expensive, most vulnerable patient population that we have. And when we move to value-based care, where so much of the focus is on reducing costs and reducing waste, our guardrails are the quality metrics that are in place to ensure that we don't do what's the cheapest way to return profits to our shareholders, which is cut services. And what worries me is that we begin to reduce waste, better align treatments with patients' goals. There's not going to be a lot of room for cost savings in this patient population, except if we start to limit services. And without those quality metrics in place, I think we run a real risk of having our most vulnerable patients and their families of receiving substandard care. And so I think we need to, in summary, better align the incentives, get our definitions clear, and first and foremost, we've got to get our quality metrics out there and into CMS's programs. Because what CMS puts forth, the rest of medicine follows, even if they're not receiving government funding.
Terrific, thank you. And Dr. Smith.
I'm an oncologist and palliative care specialist, and I've been involved in the past 40 years of trying to make healthcare more accessible and more affordable, starting with the Rural Cancer Outreach Program in Virginia, to which we added on a rural and statewide palliative care program. So I can say proudly that nearly every hospital in Virginia has a palliative care program at this point. And with my colleague, Pat Coyne, we started the palliative care program at Virginia Commonwealth University. And we're among the first to show that we had equal or better survival, clearly better symptom management, and saved millions for the health system. We duplicated that program when I came here to Johns Hopkins about 10 years ago. So we save millions for the health system and for payers, mostly by avoiding end-of-life care hospitalizations, which most people don't want. And we make I would call that better care more consistent with people's wishes, which is to avoid the hospital if at all possible, if you've set up a program of care to take care of people at home. We now reach 7% of all the adult admissions, and we've gone from 400 visits to over 10,000 total visits a year. And you'd think, well, gosh, that's a great growth of palliative care, but we still struggle every day and every year making it good. I can think of at least 4 reasons why it hasn't been taken up as much as it should. Number one, it's just hard to do. It's a lot easier for me to just double somebody's OxyContin prescription than it is to make a referral and make a referral to somebody I trust. That's the second point, is that it really requires trust in the healthcare system, trust in our case in an underserved community that may not trust the system, trust between the patient, family, oncologist, and the palliative care person to which they're referring. You really need expert consultation services. Jennifer Temmel's lung cancer study has been brought up as a great example of better survival, better symptom management, less caregiver distress. But she's had a hard time replicating that outside of her one center. When expanded to a number of institutions, it didn't have nearly as much effect, and when it done through community clinical trials networks had even less effect. So finding providers who are able to provide excellent palliative care is still an issue. There are too few fellows, too few fellowships, too few opportunities to learn how to do this. We still don't know if primary palliative care, that done by people who aren't palliative care specialists, is as good as specialty palliative care. And we've just finished a large study showing that we simply can't train oncology nurses to do this or phase 1 nurses to do this. It just doesn't make that much of a difference. And the fourth thing is the billing. I mean, you can, if you work really hard and bill appropriately, you can cover most of your salary as an internist or a geriatrician. But I can't bill for the chaplain, the pharmacist, the nurse, the social worker, perhaps even a psychologist, other addiction specialist that I might need to consult with. So we almost need a team billing code. It's much like you have a team code for early breast cancer care. And the fourth, just proceeding along with codes, it's nice that CMS has codes now for advanced care planning. It's nice that I can find them in Epic. But when we actually track those, about half the payers don't pay anything for that. And there's no recourse. You can't tell a certain insurer that Medicare says you're supposed to pay this, but you're not paying it even when we bill it appropriately. So it really dampens our enthusiasm for putting in advanced care planning and some of these other codes that make perfect sense. Even like the palliative care code, the only thing it really does for us is make our patients look sicker, so our expected mortality is closer to what it should be. So, but I welcome the opportunity to discuss all these things and see if we can come to some reasonable conclusions.
Dr. Morrison, I saw you shake your head a little bit when Dr. Smith mentioned being able to cover costs. Did you want to follow up with that?
Oh, I was just amused. As a geriatrician, it's really just hard to cover your costs at all. So I was, it's why we don't have them in public outside of academic medicine. So I was just amused at Tom thinking that. So I'm not going to touch anything more than that.
That's the oncologist versus.
Yes, the oncologist on the group.
Got it. So all of you kind of touched a little bit on kind of fee for service and moving away from that. And, since 2015, Medicare has been making this big pivot within fee-for-service to kind of alternative payment models that at least in principle should be better aligning incentives to provide palliative care. So kind of where has that left us? How has it changed the conversation, access, use of palliative care, and has it in fact in any way detracted from it? So I leave it open to whoever wants to take that on.
Let me start, and then because I think it has made a difference, and I think that we're not quite at the place yet where we really see it the way that we have in other places. But if we again look at where palliative care is strongest, which is in hospitals, it took us about 10 years to go from zero to the majority. And at the moment, you're right, there are many, CMS has moved to value-based care, and there are many who have followed that. And yet, many of us are still in markets where the majority is fee-for-service medicine. But when I look at my health system, which is 6 hospitals and umpteen primary care practices, we are starting a community-based palliative care program outside of the hospital for the entire health system because we have enough covered lives under either our accountable care organization, for which we are at risk, or through our contracted Medicare Advantage plans, which we are also at risk, so that the quality and cost incentives aligned. And I think we are beginning to see that more and more throughout the country. The other piece that makes me both optimistic and very, very nervous is the degree to which both private equity firms and for-profit healthcare systems are rapidly moving into this space because they see this as an opportunity. And again, until we have clear definitions about what palliative care encompasses for them and quality metrics, that is worrisome. So I would actually argue, Murray, that we're starting to see that asymptote outside of hospitals beginning, and we're just still early. And I'd really be curious, particularly Tom's perspective from Baltimore, and Sherry as the boss of all of us, where that's going.
We're trying to do the same thing. We're trying to standardize the services we offer across all our six hospitals. But it's hard because we simply can't find enough qualified, really good people to do this. And it requires a substantial investment, particularly up front from the health system. As you've noted, it takes a really, really very productive, driven person to cover most of their salary from evaluation and management codes. We're lucky if we cover 50% of our salaries. Part of that is because we're doing other things like teaching and research at the same time. But we need the health system cost savings to sort of backfill where we are, and not every health system or hospital can do that. Particularly in Maryland, the hospitals are very, very stressed by this odd Medicare reimbursement system we have, which essentially fixes our revenue for what it was last year, minus a little bit, because patients continue to get sicker and sicker. So I don't have any really good solutions other than to, as you say, it took 10 years to get palliative care into the hospital. It's going to take us another 10 years of training people and to get it available in the outpatient setting. That said, Gilchrist Services here has opened a very large outpatient palliative care center. Every health system in the city is trying to offer more and more outpatient palliative care. We're trying to go to 5 days a week, 2 morning and afternoon sessions for both cancer and non-cancer patients, expanding to some other areas. We've in fact embedded in gynecologic oncology, where the patients have so many needs, where we've embedded in the neurocritical care unit. That may be a model that turns out to work pretty well.
Dr. Ling.
Yeah, terrific to listen to all of this conversation, because I think, as we think about what our immediate opportunities are, we have really been focused on shifting towards value-focused care as opposed to fee-for-service. And part of this equation is particularly in settings of ACOs and other alternative payment models, bundled payments. There is opportunity, I think, to take a look at and to support team-based care, right? And team can be defined based on what people deliver the care and services that are needed to improve the outcomes. And so I think it is very dependent on having quality measures that work, even population-based measures, right, which have been quite challenging to develop in light of, any metric, any measure requires a data source. So who's in versus who's out? And I think that's part also of the challenge, the definitional challenges, the analytic challenges, like who would be the population that you can think of as really that who should be receiving palliative care services. And in that way, if we have that type of definitional clarity, walk backwards to say, well, then have the conversations about care planning and all of that great stuff that really, is the true north of how care should roll over time and space. And that actually can also define the episode of care. That, and the challenge with episodes is, so you have your population, but what's the start? And, for us on in this space, we know what the ultimate end is, but, where do we start? I think we do still struggle with last minute conversations and people not understanding what is expected of them in the care and keeping of someone who is seriously ill. And that, goals may supersede the routine algorithm of care that is forthcoming for a patient with congestive heart failure or, serious lung disease or cancer care. So this is, the definitional clarity we can bring not only on the population, but what care and services and who delivers them, I think is a real opportunity. In fee-for-service, we are limited by way of the authority that Medicare has to pay for certain professionals and not pay for other professionals. But with alternative payment models, those arrangements can be made and supported. But really, it does get down to, being able to identify and replicate where it is working. So the system that you are building, Sean, and that which you are also building, Tom, how do we identify those bright spots, figure out what's working, and also identify what is hard about this, right? What are the barriers? And it's not one barrier, but there are barriers in layers. So I think it's worth us taking a close look at what are those layers that are impediments to achieving what we all believe to be, helpful and supportive of the people who we serve.
Sounds like there's a lot of technical issues that need to be sorted out. Dr. Smith, did you want to take that on, or should I?
Oh, one of the barriers, I think we all agree that outpatient is where the action is, and seeing people while they're relatively still well, both with congestive heart failure and with cancer. I think that data from UCSF is pretty clear that in order to change the trajectory of dying in the hospital, palliative care needs to start at least 3 months sooner. I can tell you that my day as an outpatient doctor is littered with things that someone else could do. I'd probably spend half an hour to an hour first thing in the morning working on prior authorization forms. The opioid crisis has complicated my life immeasurably because I'm now having to recertify people for opioids every 6 months, having to have an opioid agreement with people, making sure that they, testifying almost under oath that I'm looking at their prescription drug monitoring plan. One simple thing would be if you do this 6 times in a row really well, you get a gold card from Blue Cross Blue Shield, or you get a gold card from Medicare, and you don't have to do any more of it. I don't see any chance of that happening, but when I counsel my young people about an outpatient career, I tell them you're going to have to live with pretty much an hour a day spent doing nothing but some paperwork. And you have to accept that.
Thanks. I did want to take us back a little bit to Dr. Morrison's comments about what keeps him up at night. And he mentioned kind of private equity and for-profit companies in light of the fact that we don't really have a portfolio of quality metrics around palliative care. And I mean, as an economist, I would argue that the fiduciary responsibility of these firms is to kind of, maximize profit. And in this scenario, the concern is you do that by reducing care. So I guess my question is for the other speakers, kind of, is this an area of concern for you, for the administration? Is this kind of the next frontier that we're just kind of waiting to catch up on, like hospice was decades ago? Dr. Smith or Dr. Ling?
I surely share Sean's concern that I see companies coming into this void and trying to skim off a substantial amount of money, and that's great for my retirement funds, but I don't think it's good for patients because, as you say, we don't really know what care those people are providing compared to what is being provided by not-for-profit organizations. And I've seen some earnings before income taxes and depreciation estimates of 17 to 21%. That's a lot of money that isn't being spent on healthcare. It's being spent on marketing and return on investment. So I would love to see some honest to goodness metrics that companies would have to live up to.
And we are also very focused on really driving to what are the outcomes that are meaningful for the people who we serve. And I think that has to be our North Star, right? What are the outcomes that, and what do each of us contribute to achieving those outcomes? I think the issue of cost and payment, I think there are many layers to it. And, however, this is again where quality and these outcomes have to be known, have to be visible, have to, in every, for even down to, the practice level, the system level, how are we doing in meeting the needs of our patients? Tremendous opportunity there, which can be achieved without, as our system capabilities are enhanced through infrastructure.
So I think that this is a good point to actually turn over. Dr. Morrison wanted to take on several questions from the audience about definitions, because I think that fits in kind of quite nicely here. So Dr. Morrison, how do we define these things?
Yeah. So I just wanted to, I know there were a number of questions that came up in the Q&A, and I thought I could just get them out of the way first. It's not that we don't have a definition of palliative care. We do, and it took a long time for all of the organizations involved in the care of people with serious illness to get together. But we have a consensus definition that palliative care is focused on improving care for people with serious illness and their families. It's provided at the same time as all other appropriate care, including life-prolonging treatments, and it's provided to persons of any age, and that ideally it should begin at the time of diagnosis of a serious illness. We also have a good definition of serious illness that work by my colleague Amy Kelly has done, clearly defines who the denominator is. So what's the stumbling block between getting from A to B? Well, the first around the definition of palliative care is that although the field has a consensus definition and consensus guidelines about what palliative care should be and what it makes to call yourself a palliative care program, we have not had the $30-40 million necessary for a public relations campaign to inform and educate the public about what it actually is. Remember, this is a very new field that started in the mid-1990s that nobody really knew existed. So that public relations campaign has not happened. The question about the denominator and finding people with serious illness is a soluble one, but a challenging one, because one of the key variables to determine whether somebody will benefit from palliative care is their function. And at the moment, there is not a measure of function in any of the data sets that we routinely use to assess quality. So if CMS wanted to do public reporting, for example, on a health system penetration, palliative care penetration, they would need to have the functional status of everybody in that system. And we just don't have a way of getting that right now. My one wish would be put functional status as a reporting measure. Yeah. And then the third issue is that there's really no way right now of enforcing what a palliative care program is. There's no stick. The Joint Commission has an advanced certification program, but having a palliative care program is not either A, a condition of participation in Medicare, B, it's not a condition of accreditation for any healthcare program in this country. And so not having palliative care as defined by the National Consensus Project as a necessary component of healthcare means that the only way it spreads is through both good intentions and forward-thinking healthcare systems. And I think that those are the challenges around the definition. One is public relations campaign. Two, a lack of the key measure to measure who the serious illness population is. And three, it's just not included in our accreditation and certification programs right now.
Dr. Ling, did you, or Dr. Smith, did you want to follow up on that?
Yeah, I would love to respond. And I think, the issue of measuring function and reporting on function, I think, is a really important point. What we have done thus far is we already have standardized, as authorized by the Impact Act, standardized the data collection, the data elements for reporting on function, mobility, self-care, cognition, but the scope of the implementation has been in post-acute care, right? Skilled nursing facilities, home health agencies, long-term care acute hospitals, and CMS did not have the authority to extend to the ambulatory physician space, nor did CMS have the authority to extend into the acute hospital space. It's something that if we had that authority, if we were granted that authority, it would be fairly simple to do because we already have done the hard work of standardizing those data elements. And the point there is that not just for quality reporting purposes, but those same data elements by way of the data element library, which is, it's something can be useful for research purposes, but also these data elements were decided upon because we thought it would be clinically helpful to know what a person's level of function was across as they traverse the healthcare system, right? Because otherwise you always never sure, is this a new deficit? Is this, is it progressing? So I think that is really an important opportunity. I think we have also, I think cognition is probably the toughest of all of that, just over time and space and, 1,000,001 cognitive tests that I have known. They all are assessing something similar, but everybody loves their tests. So I think there is tremendous opportunity, Sean, and would love to see us seize that opportunity.
Jerry, can I just ask, to get you authority, that requires an act of Congress, correct? I don't want to go down a rabbit hole, but
authority.
I know
it's
not in your authority.
That's required. Yeah. And so, yes, we have to. So the Impact Act was the original authority, and it would be refining the scope of that act. Now, having said that, it's also helpful to have data that suggests how feasible would it be to measure, right, in ambulatory care. Now, it's a bit of a chicken and the egg because you need authority to require it, but certainly could be voluntarily collected. And I will say, in the cognition space, we actually had difficulty finding test sites, systems that were willing to give it a go and try to submit for voluntary purposes information on cognitive function. I think there's, especially in systems that are electronically health record capable, a lot of the hard work has been done. So maybe that would be a place to voluntarily start as opposed to requiring it to be started. Hopefully that helps answer the question.
That's great. I realize we've talked a lot about Medicare, and that makes sense, given the population, but there has been movement in Medicaid, managed care in particular. Here in California, we passed SB 1004, now requiring health plans serving Medicaid managed care to provide palliative care services. Dr. Smith, you said you worked with the state of Virginia to expand palliative care access, and we're seeing other states kind of moving in this direction. Anyone want to kind of comment on what's going on in Medicaid and kind of what this, what if anything it foreshadows? Are they doing different reporting please feel free to jump in and let us know.
I think the vertically integrated healthcare models like Kaiser and Geisinger Clinic are probably our best model for where to go. You have a certain population, the number of covered lives, and you decide how many geneticists you need for 400,000 covered lives, and you decide how many palliative care specialists. And then you can hire really good ones and keep them there so they can establish trust relationships with the other providers and continue to expand. I think Medicaid is, I really worried about Medicaid because to me, it's always seemed like it's so underfunded to begin with. And I just see so many opportunities for any lump sum payment model to just not allow enough money to be spent on the person who should be receiving the care. I mean, it's definitely a conflict of interest when you're providing the money as a lump sum to the group that gets it, but we've learned to accept that.
I guess my experience, Marianne, I'd really be curious about Sherry's perspective on this, is the challenge with Medicaid is you got 50 different Medicaid programs. So trying to create both a programmatic model and a reimbursement model, in many respects, you have to do it almost 50 different times. And it's working with, the folks at CMS is terrific because you know who you're working with all the time. But if you go to the Medicaid level, you start, even though it's the CMS funding, you start working at the state level, and that gets really, really hard. And we've seen some great work that's come out of some progressive states like California, Oregon. I know Tom's work in Maryland, and trying to do it, another 47 times is really hard.
Yeah, and just to add, I think our federal programs and those who run it really want to enable states to get to the right decision making and support the states, but are also mindful of the authority and overreach, which I applaud those, California, Virginia, others. And it is not to say that we couldn't, again, highlight, bright spots and say, hey, have you noticed? Here's what's happening in another state. It would be just challenging to require it because it is a matter of, then it's state authority as opposed to, the federal program.
Thanks. So we haven't talked at all about COVID-19, which maybe is a good thing. Maybe we're moving on, but I am curious about your reactions to kind of what we've learned during the pandemic about kind of palliative care and its opportunities. Anyone should feel free to jump in here.
Well, as a New Yorker who got the first real taste of COVID in the spring of 2020, I think that it dramatically changed how we are perceived within our health system and within and the role that palliative care can play in the setting of serious illness. In that, because of the strain on our emergency departments, our critical care units, and our hospital services, palliative care was really used extensively as the added layer of support for patients and families. In terms of goals of care discussions were undertaken by our team, and that allowed the emergency department physicians to focus on respiratory management. It allowed us to make sure that patients' treatments were in line with their goals, so they went to the right place in the hospital, which really helped us to utilize very, very scarce resources. The communication skills, specifically related to families, were incredibly valuable to all of our system because families weren't allowed to be with patients. They just weren't there. And I think the other big intervention that we saw was the need for our clinicians to have somebody who worked with people with serious illness all the time to help with their well-being. Because they went from taking care of one type of population to taking care of exclusively a very, very different population, all who are at very, very high risk for death, and of all different ages. And I think that component really brought palliative care to the forefront of system leadership. And my challenge as system chair now is not so much getting buy-in, it's workforce, because I have too much buy-in. And I have too many people wanting our services and not enough providers to do that. And I think if there's any bright light from COVID, that was perhaps it for us.
That's great. So again, back to Dr. Smith's comment about needing kind of the right caregivers or clinicians to kind of round out the team. And there were kind of some questions from the audience about this, about kind of not just standardization of quality metrics, but of the services and providers, and kind of what is going on in that front. Is that part of the work being done to try to clarify definitions here?
I think we don't know what the optimal team is. If you look at Jennifer Temmel's landmark New England Journal study with 157 lung cancer patients, they saw the same nurse practitioner, advanced practice nurse, or the same physician once a month. It wasn't a team, they saw one person, but it was that continuity and continuity by expert providers with the backup of a social worker and a chaplain and pharmacist, if needed. That's probably the essential part. I think it's that continuity and expertise that is probably the most important part of any palliative care efforts.
Sounds like there's still more work to be done on that. Dr. Ling, please.
Yeah, Murray, thank you. And it really is a relief to hear that, amidst COVID, that palliative care resources and skills were being deployed. My worry, just tracking to at a national level, the number of locations that were switching to what is termed as, crisis standards of care. What is behind that? So it is not just about resource allocation to keep people alive. And I mean, that's important, but, invisible to us from where we sit is the extent to which individuals' goals of care were actually, respected and supported, as opposed to decisions that were made because of a specific phenotype of a person, right? And I think, we have been supporting really having clinicians know what their patients' care preferences were. Admittedly, often this is happening way too late in the game, but if it were known and if that information were readily available, then the crisis standards could actually be aligned with an individual's care goals. But I did and do have some worry that, this entire type of discussion, the content that really maximally supports what people want out of the healthcare system for themselves and their families, that, that there wasn't opportunity to actually go there at the peak of the crisis. So I think that is, as we look ahead, I think it is worth noting as one of our lessons learned, what did we learn here and how do we better prepare? Because it is, we were surprised with the first round, and yet we were already working to enhance and lift up palliative care and, advanced care planning, not just DNR, DNI, but really meaningful conversations. So I think it would be worth revisiting that in light of COVID, hopefully in our rearview mirrors. But I think, how do we better learn from what we went through to shape a different and better future?
Sherry, I don't think it's a coincidence that we never, across our health system in New York City, had to put in crisis standards. During the entire spring of 2020, we watched as other health systems throughout the country talked about it. But even with patients in Central Park, we never had to go to crisis standards because I think of the penetration of palliative care in our health system, among others.
Mm-hmm. Mm-hmm. I think that's those are two really important concepts to connect, right? Preparedness, and what we're trying to achieve through enhancing palliative care. I don't think that connection is readily known. I think they're two separate parts that if we could bridge as a lesson learned would be helpful in our preparation for our immediate future. But thank you for pointing that out, Sean.
Dr. Smith, did you want to add something or?
No, I don't really.
Okay.
All I know is that we have stayed incredibly busy all through the COVID times, and so many of our providers got pulled to work on regular COVID units that there were very few of us left to do regular palliative care. So I hope that doesn't happen again.
So I feel like I would be remiss if I didn't mention this and get your reaction, which is that normally when we think about, the value of care, we think not about cost savings, but is it worth the cost? And really a lot of the conversation around palliative care is it cost savings? What if at the end of the day, it's not cost savings, but it's still worth the cost? How do we move the conversation away from cost savings to back to value? Is it worth the cost? Are the benefits worth the cost? So I'll leave it at that for your kind of final thoughts. No one wants to take that on.
I think you're hearing, sort of agreement, Maria, as somebody with Tom, who's done a lot of the early economic analysis of palliative care. I really think it's, we should be paying for this. It's just the right thing to be doing for our most vulnerable, most sick population. And it is a measure of the quality of care that we should be providing. If we can't do a good job with these people, we can't do a good job as an entire healthcare system. And yes, we should be paying for it. It just makes sense in so many different ways. And we should move beyond, well, are we going to save money or is it really cost effective? It's just good care. It's the right care.
I couldn't agree more. You wouldn't start a new immunotherapy program and expect it to save money right off the bat. What you would be hoping for would be better quality of life, perhaps extended life, but at a cost that one could afford. So applying the usual standards of cost effectiveness towards it, recognizing that in the US, you're not allowed to even mention that word, but other countries do. So I think we're lucky that our administration really understands this. Part of it is we got the fiscal analysis unit involved early on and showed them that this wasn't going to cost a whole lot more, if anything. And in fact, it would be beneficial to the health system, beneficial to patients because their copays would be lower, and beneficial to payers at large. But it wouldn't generate major cost savings. It would just generate enough cost savings to backfill so that we could pay reasonable salaries and attract people into the field.
Thank you. So we're right up at 10:30. I want to thank everyone, Dr. Ling, Dr. Morrison, and Dr. Smith for participating in this really fruitful discussion. And thank you to the audience for joining us. I really, really appreciate it.